he received a topic that said RAI not necessary in low risk tumors. So that's what he's prepared. If
I think we just open it up for intermediate risk.
so, okay. So what he said is that he would rather not present because it's not relevant, and
I got a page.
he would be happy to just participate in a discussion, and if we can open up the discussion here. So thankfully, Archie actually did cover both viewpoints. You did say necessary in some, unnecessary in some, and possibly indicated in some. So I guess she's covered both of the spectrums. Are there any questions we can take up front
Yeah,
or
Ritesh.
comments? Let me start at
Ritesh.
the back, sir. Yeah, please.
Good afternoon, everyone. Dr. Archie, it was a very nice presentation, lucid one also. My query that suppose if a patient has a multifocal tumor, bilateral, collective size is 2 centimeters, 4 foci, how much dose, and no lymph nodes, how much dose you will give?
That's the only thing, like only multifocality around 30 to 50 millicuries.
In which patient you will give the dose on an OPD basis?
30 millicuries because
Which patient?
okay, so if we are very sure you want to have, I mean, that it is less than 4 foci, you will give 30 millicuries, or in patients who have smaller size nodes in the central compartment, those patients you can consider 30 millicuries.
So my question is open to how?
For aggressive variants and vascular invasion, I would give high.
Definitely.
Yeah.
So my question is open to house if the patient is a low or intermediate risk. Why can't we give the patient RAI benefit on in a OPD setting?
So he's supporting my thing. So
Okay, it's a question. Let me rephrase it. Dr. Bal, you had a comment or a question first? We can take that comment. Can we have a mic?
Yeah, very nice. I will be going in favor of Dr. Chaukar. Dr. Chaukar, he did not mention anything, but I will, on his favor, I am arguing. You see, the ATA guideline says intermediate, low intermediate, and intermediate to high. That's what. So they have intermediate group, they have divided, because bulk of the tumor is intermediate group, and intermediate group they have subclassified, artificially subclassified into two. One is low intermediate and a high intermediate, or intermediate to high. So there is no exact cutoff. So these numbers, whatever you show, is all this humbug. There is nothing. In America, they don't do any diagnostic whole body scan before giving radioactive iodine. That is another issue. That's why if your histopathology is intermediate risk, you should give iodine. That is 30 millicurie, 50 millicurie, 100 millicurie, 200 millicurie, whatever you want to do. Do radiotherapist will ever treat any patient, say oral cancer, without planning? Small commercial carcinoma, without any doing planning, you'll just give say 60 gray. Will it be given ever? Never. Never it is given. Why all these years nuclear medicine always give 30 millicurie, 40 millicurie? It's all empirical, not based on any data. If somebody feels it is 30 millicurie, let's give it 30 millicurie. It's never. If I have more than 1,500 patients whom I have never given radioactive iodine. Out of that, more than 600 patients who have intermediate risk, I have never given radioactive iodine. And we just published in Clinical Endocrinology showing that people who have given radioactive iodine intermediate risk and the people who have been surgically removed everything and nothing to ablate, and if you don't give any radioactive and follow them, the ablation, the recurrence rate is 9.6 versus 10.2. So whether you give iodine or no iodine doesn't matter. Then, if you have done a diagnostic whole body scan, and Dr. Deepak has done a wonderful job, and half of my patient comes from his surgical patients, they have not given radioactive iodine. If you given even if 30 millicurie or 100 millicurie, you will be only ablating the salivary glands and gonads, which they will never be benefited. What Americans they do, because they have to give $5,000 cost of TSH, recombinant TSH, and do the scan, and then order the iodine, then give another recombinant TSH, and it will cost around $20,000. They say, give everybody 50, give everybody 100, give 30. It's all nonsense, humbug. They don't have any data. We have data. We have followed them more than 10 years. More than 300 patients we followed meticulously for 3 years. Half of them not given radioactive iodine, half of them given empirically given radioactive iodine. The outcome is same. This is because they do many times the so-called evidence is actually convenience based. They never do any whole body scan. When I published my paper in '96 showing that low risk only need 30 millicurie, they criticize left and right. And then in 2015, they put in the guideline 30 millicurie is enough. Before that, I have to publish 3 papers in JCM in their own journal saying that 30 millicurie is more than sufficient to ablate the remnant. Because if you give 200 millicurie, you will be only giving salivary gland and gonads. Now they come back to say. So what I'm trying to say, you must categorize the patient not because on pathologist report. You must do a diagnostic whole body scan. If there is nothing in the scan, you are not going to take even a millicurie. Why should you give? That's my argument. Thank you.
Okay.
So Deepak, since you have 5-10 minutes.
Yes.
There are two scenarios that I try to present. One is that how many of you would not give a radioactive iodine if patient is, that low risk is categorized as less than 2 millimeter foci or less than 5 nodes. So if you have a central compartment done and say you've got 2 nodes positive, you don't have total thyroid, how many of you will not give radioiodine just because they were less than 5? Do we now not give radioiodine? Only 2 hands going up. Now more. You will not give radioiodine. So others are still giving radioiodine. So the practice is not yet changing. And so that's, Dr. Bal, we are still wanting to give radioiodine if there is lymph node positivity. Yes, Prathamesh.
Devendra, what Dr. Bal was trying to say also was that we are dependent on pathologists to make this call, to take this call. And how many pathologists actually will give you this information? So the whole
Information pathologist will give.
no, we're talking of the micrometastasis.
Micromets leave it,
In
but the 2 node positive.
How many
less
nodes
than 5.
positive, and how many angio invasion? Now these are things that
We won't get.
Now we are looking at it objectively from the ATA guidelines. We would need our pathologists to conform to this, and then we need to make that difference. If they cannot conform to this, then we will not be able to make this low, intermediate, and intermediate high risk difference. So my take is, we need to first look at the pathology and then understand. If you find multiple nodes, you would consider doing a total thyroid.
Prathamesh, I have
Right.
seen patients where the report has said less than 4 foci of vascular invasion, and patients have come with, distant metastasis now in 7 years, 8 years time, they have come with distant metastasis. So definitely it was not less than 4 vascular foci, not a limited vascular foci, but multiple vascular invasion.
Archie, for
Must
last
have been
10 years, 2015 to 2025, how many pathologists have been converted to the academic pathologists? They remain
Absolutely.
same.
Correct,
Only
correct.
academic, Tata, AIMS, PGI doesn't make up pathologist of the country. Still, I get a one line, I have more than 12,500 patients in my follow-up in this country. Anyone has got that much of personal experience, I have. And even 50% of the patient I get classical papillary thyroid carcinoma. Not mentioned in what is the site. Forget about the vascularity and all this. Never. So on that basis, we are going to treat.
Okay. So we have 8 minutes. There are a couple of clinical scenarios I would like to put up and get answers and thoughts on what you would do, but we'll take your
Yeah.
question.
So
comment
one question, as Dr. Bal has also said, now we should, rather than empirical based, dosimetry based or something. So do we recommend that in intermediate, low grade risk, we always subject the patient for a scan, see for the uptake, and then only take the call, apart from the histopathology?
So
So all patients, so that's
A simple yes, no would do. Yes. Okay. So I think when we're going to do some clinical scenarios, let's preface it by saying,
yeah, just the scan, not the
I'm
30.
doing a diagnostic scan.
diagnostic scan. I think agreement is yes and practice is yes. So let me put some clinical scenarios.
Empirical only.
For
Nowadays,
discussion.
you don't do dosimetry because it's like a lot of work to do dosimetry, and we are not doing as such that.
Okay. So let's preface it by saying whatever scenarios I've got some in my head, I would really like to know what you do. Is you have the surgery, you have the pre-op sonography, you have the operative availability, you also have your diagnostic scan and thyroglobulin results available. And that's what you're going to base your decision on. So let's work with that model. So vascular invasion, you mentioned vascular invasion. Now, my understanding is WHO says no longer is less than 4, more than 4, very relevant. It's a continuum of risk from 1 to 20 vessels. And there is a lot of interpathology variation when reporting. It's not easy to pick up, differentiate lymphatic from vascular. So my question is, any vascular invasion, would you give RAI? No other risk factor. Seems low TG, diagnostic scan showing only thyroid bed uptake in acceptable levels.
Yes, I would give radioactive iodine.
Any other different thoughts? Sir,
We are
just
doing
one
a
second.
scan, irrespective of that.
Archie, let me,
Nothing comes in the scan.
We are not treating anything.
That's exactly
Yeah.
the point should be given.
But however,
After
when a
pathologist, you should classify the patient, they really has got something to be ablated or not. You are not giving a ghost treatment for even 30 millicurie, I consider it over treatment. The iodine is not toughies, and you can take as many toughies you like.
Okay.
Scenario is, how many of you look at post total thyroidectomy, look at the thyroglobulin at say 6 weeks, and then base your decision whether or not to give radioactive iodine? So if your TG is less than 1, would you then want not to give radioiodine, irrespective of if it's a low intermediate risk also? How many of you go by that route, saying if your TG is normal at 6 weeks or 8 weeks, then maybe not give radioactive iodine? Because that is one thought that people say, that base it after total thyroidectomy on your TG levels. If TG is normal, then there's a case to avoid radioactive iodine.
See, if you are doing the TG, it is a stimulated TG. If the patient is already stimulated by TSH with thyroid withdrawal, then better to do a scan at the same time,
To do a diagnostic scan.
diagnostic scan, as well as anti-TG also and sonography, and then take a call. That is a better idea.
You could also do a recombinant TG.
taking that, taking your thing, whenever you are doing such a scan, you are just going to see the remnant thyroid. So at present, we are not basing our giving radioactive iodine or no based on TG post-op.
Okay.
So your TG could be normal. In aggressive variants, you will have a TG which is less than 1, 2 or whatever. And then you do a radioactive iodine scan, you will see the remnant uptake, but you will still go ahead and treat.
So my question to Dr. Bal and to you also, in your whole entire career, how many times in the low risk patient, when you have done the diagnostic scan and found metastasis?
4% patients. I have seen occult metastasis in the spine, I have seen occult metastasis in the head of the humerus.
So that means 3 to 4 is a
So
significant number. It is
initial
not a
part,
simple number.
post-surgery, thyroglobulin is not reliable, for your information. Post-surgery, thyroglobulin, it can be high. In this country, 15 to 20% patients have got Hashimoto's thyroiditis. They will have antithyroglobulin antibody. So their TG will never be positive. So how will you assess? So first 6 months, if your antibody titer is showing downward trend, that means it's natural, which is coming down. If it is stable and goes up, then there is something.
So
there.
as you told, 3 to 4% is a significant number. That means we should do diagnostic scan
You
in
have
every
not
patient.
read the 2025, even in the low risk, they have written 10% is recurrence rate. So that is a mixed bag. They just throw anything. So
Okay.
in their own paper,
Can we take Mitali's comment, please?
So, to understand it better, the situation that you said was low intermediate. Patient post-operatively has no stimulated thyroglobulin detectable. So why would for a low intermediate, I would have observed the patient rather than subjecting
Okay, so
them
the question is low intermediate, only minimal bed uptake, ablated thyroglobulin. Any role for RAI?
So low intermediate, again, what I said, that, you should be very sure that you are having proper low intermediate as per your pathology report, then there is no need of giving. But what we were speaking of was total, on the whole, intermediate risk when
the
there are
whole group.
aggressive variants
The
or
whole group
vascular
which has
invasion.
many variations.
Correct.
was, we must factor stimulated thyroglobulin levels
So,
when we are
I
looking
think
at
we all agreed, stimulated TG and diagnostic scan for a complete workup, and then base it with that information. So microscopic, 2 minutes. So maybe one more scenario I'll put up for you. So microscopic ETE doesn't change the T stage, and it puts it in intermediate risk group buffer.
Microscopic ET, if it is T1, T2 tumors, it's in the low
No, it doesn't
intermediate
change the
risk
T
categories.
stage. TNM, I don't think it changes TNM.
Okay, yeah.
The
In
T
TNM
stage.
it doesn't, yes.
Right. It
In
puts, but it
ATA
puts you in intermediate risk group.
Correct.
That's what I was coming to.
Low intermediate.
So let's say I take out a tumor that's 2 centimeters. It had posterior capsular stretch. It came off the nerve well, but clearly the stretched capsule, oblique tumor capsule, was in contact with the nerve. It came off the trachea fine. I'm very sure there is no residual disease gross. As a surgeon, you can't be sure you haven't left behind microscopic disease. Assuming there is no other foci of disease in the body, this patient is likely to have just thyroid bed uptake, possibly a very low TG. Would the surgeon's interpretation that I've stripped it off the nerve lean you into giving RAI, even though you have a negative diagnostic scan and a negative TG? Because the volume is microscopic.
Yes.
But that's a place you don't want to deal with recurrence. You don't mind dealing with nodal recurrence. You don't want thyroid bed recurrence. That's just rough. You would give this. So surgeons, I think this is key for surgeons. The nuclear med only gets the path report.
So
that
Deepak-
is what you gave the pathologist. it does not get the information of what you left behind in the patient. That only you know. I think that information must be conveyed to nuclear med so they can make the right decision.
Yeah, so now,
So what would be the dose you would give in this case?
250 millicuries.
So remnant ablation dose, a low dose. Fair enough. Devendra.
the ATS now I think distinguish between for the risk stratification anterior versus
Yeah,
posterior.
anterior is lower risk and posterior is a little higher.
goes into intermediate.
But they're all still intermediate. They're all still intermediate. So I think what we've got is intermediate is a mixed bag. Certainly pre-op, intra-op and post-op path gives you some stratification. Diagnostic scan and STIM TG will help you stratify better. But there would be some cases you would give iodine and a good proportion of cases you think would not be needed. Is that a fair summation or are there any other questions? Please, we can take one last one, I think. Then we'll wrap up.
Thank you. My question is a little basic. So what is the remnant uptake level which is acceptable? 3%, 5%? And that is one. And second is we keep telling 30 to 50 millicurie. So what is the dose based on and how do we calculate or give it?
Okay, so the acceptable, these days no one does uptake, but when you see a large remnant and the uptakes are more than 15%, then it says that the patient should be sent again for a resurgery, but we hardly do that. Till 15-20% we try to do the ablation because going in for surgery again would be very difficult. That's your first question. The second is there are multiple ways of calculating the dosage, but multiple studies have been done which have said that even if you give empirical doses, they give the right amount of dose that is necessary to do either the remnant ablation or treatment of the metastasis if they are present. So we follow empirical dose. So if it is low, intermediate, and you will see the pathology, we also see the peroperative notes.
Right.
And if the surgeon writes to me and says that it was close to the laryngeal nerve or close to the trachea, I would err towards giving radioactive iodine. So that we all do. So what we do is just empirical.
Final word, Devendra. You didn't get to speak here, so you may have the final word.
I think intermediate risk I would give radioactive iodine, sure.
Fair enough. All right, thank
May
you.
I ask one question? Last question, sir.
I don't know if we have time.
So we have a patient of low, intermediate or risk patient, does the age of the patient, we include the age of the patient in making the
Influence
diagnosis?
the decision. So,
Very-
so let's
very
put it
young
this way.
patient, very young
Intermediate
child.
risk group, diagnostics can only bed uptake, low amounts, TG undetectable. 65-year-old versus 40-year-old. Would it matter? Well-differentiated thyroid carcinoma, classical PTC.
If you go by the guidelines, they would say no.
What would you
you're
do?
Not given, but I would err towards giving a small dose of radioactive iodine so that the patient is free from getting recurrences, because that will save the patient's morbidity and the thing of having a reoperation again. So with a 65-year-old, I don't want to go and have problems. I think the surgeon would also bend towards me and say that yes, go ahead.